How do you recognize and manage diabetes in patients receiving immune checkpoint inhibitors? Another possible side effect patients are taught when undergoing immune checkpoint inhibitors is diabetes. During their visit, they are often taught signs and symptoms of diabetes, such as excess thirst, frequent urination, general weakness, vomiting, abdominal pain, dry skin, dry mouth, increased heart rate, and fruity odor on the breath. Diabetes can occur in patients without any history of or can compound issues in patients with pre-existing diabetes. When giving immunotherapy, we generally check labs before each cycle and monitor glucose levels. A possible result of diabetes is DKA, which is diabetic ketoacidosis. If DKA is suspected, you would want to evaluate per institutional guidelines, including blood pH, basic metabolic panel, urine or serum ketones, or NI and GAP. If urine or serum ketones is positive, you can consider drawing a C-peptide. If type 1 diabetes is suspected, also consider anti-GAD or anti-islet cell antibodies. One thing to note is high-dose corticosteroid use for other immune-related adverse events may induce or exacerbate hyperglycemia. If corticosteroid-induced hyperglycemia is suspected, evaluate benefit-risk ratio of tapering corticosteroids for glucose control versus management of the immune-related adverse events. These are some guidelines for how to manage different grades of diabetes. For mild hyperglycemia, you would continue the immune checkpoint inhibitor. Monitor serial blood glucose at each dose. Teach patients about diet and lifestyle modifications, and if necessary, provide diabetic medication per your institutional protocol. You can also consider an endocrine consultation if patient is symptomatic and the hyperglycemia cannot be controlled. For moderate hyperglycemia, you can continue with the immune checkpoint inhibitors. Consider an endocrine consultation. Monitor serum blood glucose at each dose, and teach patients about diet, lifestyle modification, and provide diabetic medications per your institutional protocol. For moderate or severe and or highly symptomatic DKA, you would hold the immune checkpoint inhibitors, provide inpatient care, or if you're able to get an urgent outpatient referral same day, then you could do that. Insulin is to be provided as directed by the inpatient team and or the endocrinologist. And if the patient is admitted, these are managed per institutional guidelines. Some things that can be given are IV fluids, IV insulin, and hourly glucose monitoring. You can consider resuming immune checkpoint inhibitor therapy once DKA has been corrected and glucose level has been stabilized. Some red flags and emergency situations is if patients develop signs and symptoms of DKA, which include confusion, vomiting, abdominal pain, diarrhea, trouble breathing, loss of appetite, fatigue, or fruity odor on the breath. You would need to hospitalize for the management and hold all immunotherapy until well controlled. And consider permanently discontinuing the immune checkpoint inhibitor if indicated. You would need to provide patient education on signs and symptoms of hyper and hypoglycemia. Provide insulin education if the patient needs insulin, or refer to a diabetic educator. Discuss possibility of other immune-related adverse events, including others of endocrine origin. Talk to your patient about dietary modifications. And for patients with new onset type 1 diabetes, discuss that it will most likely be permanent.